Okay, good evening, everyone. We are going to commence the surgery MCQs for today, and God willing, we are going to take 100 questions. So we'll be relatively faster than usual, because if we are slow, we'll take only 20. So let's go on. The first question says, all are true regarding wounds except A, contusion results from injury of tissues subadjacent to surface epithelium. B, lacerations are open wounds, usually with regular edges. C, where the wound enters a cavity, it is described as penetrating. When the wound entirely pass through a cavity or organ, it is described as perforating. Where portions of the anatomy are wrenched away, the injury is an avulsion injury. So the instruction here is choosing the single best option. Is it clear? Now, look at these options carefully. They are definitions of different types of wounds. When you say contusion, it's a type of closed wound. Contusions, hematomas are closed wounds. Ecchymosis is a type of hematoma. Do you understand? Contusion and bruise are the same thing. Bruise. They are closed wounds where you have intact overlying epithelium with a subendothelial or soft tissue injury. That is contusion. It's an example of closed wound. Hematoma is also a closed wound where you have extravasation of blood into tissue that is not in continuous with the circulatory system. That is hematoma. Do you understand? So A is correct. Is that not so? Is it correct from what I just said? Laceration is an open wound that is caused by either a blunt or sharp object producing a ragged edges. That is what laceration is. Most of the time it's wider than deep. The characteristics of laceration is ragged edges or rough edges. So if you look at that option, it says regular edges. That makes it false. Where the wound enters a cavity, it is described as penetrating wound. Now, if you have entry of a sharp or pointed object into a body cavity, that is a penetrating injury. For example, stab to the chest cavity is penetration. Stab into the abdominal cavity is penetration. But if this penetration enters and exceeds a cavity, it is called a perforating injury. Last month, there was a young lady that was driving in the night. I was called to rushly see that young lady. She was driving in the night, about 25-year-old lady, well-dressed. She ran into a pickup that is carrying metal rods. It entered her windscreen, entered her neck, came out through the back of her neck, avulsing the jugular vein and the carotid artery. Within 10 minutes for me to drive from where I am to where they rushed her to, she died. So that is a form of perforation. It entered and exits. So you have an entry and exit point. That is a very devastating injury. If the perforation is caused by gunshot, the exit point is usually larger than the entry point. Gunshot injury is so unique that it has a category on its own. You classify the injury by gunshot as gunshot injury. The effect is not only penetration or perforation, it has what is called cavitatory effects. Okay, now let's proceed. So B is false, C is correct, D is also correct. When it enters and exits a cavity, is perforation. Where you have avulsion injury, there is a wretched part of the body or a tissue. Degloving, detachment. When you have forceful detachment of a part of a tissue, that is avulsion. And avulsion could either be partial or complete avulsion. Partial avulsion still has a stalk of blood vessel attached to the part of the body that is detached. So that part bleeds more than complete avulsion because it still have, what do you call it? Blood supplying that. Which of the following is not true in the management of wounds? That is, which is false? A, prompt action is described primarily to arrest bleeding. B, wounds older than 4 hours should be sutured. C, where there is doubt, delayed primary closure should be done. Initial debridement is in most cases should be conservative. Dead space should be eliminated by buried sutures rather than external drainage. Now look at these options carefully, okay? Which is false, not true. Prompt action is described primarily to arrest bleeding. Wound older than 4 hours should be sutures. Now, when an individual sustains an injury, when it is within the golden hours of injury, you suture primarily. When it has exceeded the golden hours, you do what is called a delayed primary closure. Because that wound is contaminated, if you close primarily, it becomes infected when they have exceeded the golden hours, which is 4 hours. Any wound presenting beyond the golden hours is regarded as a contaminated wound. So you just dress, leave open for 3 to 5 days, allow edema and inflammation to subside before you close primarily. Okay? Now, B is false. B is true. Is it true or false? B is true or false? Okay. Where there is doubt, delayed primary closure should be done. Where there is doubt, what is delayed primary closure? What is delayed primary closure? Is when a patient presents with a contaminated wound. You don't want to suture primarily. You allow inflammation and edema to subside in 3 to 5 days before suturing while you dress the wound. before that time. That is called a delayed primary closure. It appears you don't know what are the various type of closures. That is where the confusion is. Is that also? Tariq, there's no confusion. Primary closure is done for a surgically incised wound. They are well opposed, no any inflammation, you put sutures to close them. But delayed primary closure is a contaminated wound or a dirty wound or wound that has exceeded the golden hours. You don't want to close primarily, it becomes infected. So you dress and allow for inflammation to subside. After 3 days, 3 to 5 days, you close. That is delayed primary closure. Secondary closure, okay? In secondary closure, there is associated tissue loss. Do you understand? Secondary closure, and you should differentiate secondary closure from secondary wound healing or healing by secondary intention. Go and find out the difference. But in secondary closure, a dirty wound, you allow to granulate well, no more discharge, you undermine, raise flaps, okay, bring them together and close. That is secondary closure because the edges will not come together because of this tissue loss, okay, and maybe it's infected. Initial debridement, in most cases, should be conservative. True or false? Initial debridement should be conservative. Dead space should be eliminated by buried sutures rather than external drainage. So let's go back to the question again. Then I want somebody to attempt to answer. Which of the following is not true in the management of wound? Which is not true? Yeah. Yes. So where there is doubt, delay primary closure should be done. That is correct. Initial debridement, in most cases, should be conservative. Dead space should be eliminated by buried sutures rather than external drainage. Okay, you can bury suture, especially if it's a clean wound. Do you understand? But if it's a dirty wound, it's better you put place an external drainage so that you don't. So B is the false answer. Now, in missile and firearms, I think we need more fans here. In missiles and firearms, the damage is essentially a function of the velocity at entry and exit of tissue. True or false? Rifle bullets are considered high-velocity missiles. High-velocity missiles are associated with phenomena of cavitation. Blast injuries are generally more damaging than bullet wounds. Yes? Now, as I was telling you about gunshot injury that has a category on its own, okay? Now, you see, there are different types of rifles, or there are different types of firearms or missiles. You have shotgun, long gun. Okay. Now, long guns are high velocity. They transmit bullets at high velocity. And the higher the velocity, the more the damage. Now, rifles or long guns, they create more damage than shotguns because they have higher velocity, you understand, and momentum, because that is mass times velocity that gives you the momentum. Do you understand? But shotguns, the velocity of shotguns are lesser than rifles or long guns, and the mass of the bullet is smaller than long guns. So the momentum in shotguns is lesser than that of long guns. So which one will cause more damage? Long guns. Is it clear? If it's not clear, that means you don't understand physics. Momentum is mass times velocity. And the mass of long guns, the bullets of long guns is heavier, and their velocity is more than shotguns. So they tend to give more damage than shotguns. And they have entry and exit point. I told you the exit point usually are wider and bigger. However, the damage a shotgun will do at a closer range is higher. Damage a shotgun will do at a closer range is higher. Rifle bullets are considered high velocity missiles. High velocity missiles are associated with phenomena of cavitation. Blast injury are generally more damaging than bullet wounds. So what is our correct option here? Is A correct? I just told you physics now. Damage is a function of what and what? Mass and velocity. It's not a function of entry and exit points. It's mass and velocity. So that is the only wrong answer there. You know, the option is single best option. It might be the only odd one now. I don't know if you understand. If you look at all other options, they are correct. That's why you guys are confused. Because you are seeing multiple options there. You are happy, Hausa? You are not happy? See, all these other options are correct except A. Is it clear? But is it understandable? What is the confusion there? Hausa? Which one is confusing? D. You see blasts. Huh? There are several phenomena involved in blasts. Okay? The issue of sucking in air. Do you understand? The issue of several fragments within the blast. You have a lot of shrapnels that can have a velocity of a bullet or more. You know, those blasts will have a lot of fragments in them. After the blast, you have several shrapnels with a very high velocity. Explosion from the air that is generated and all that. So the overall effect of blast is more than that of a bullet. Wound healing is in our patients is essentially a process of A, resolution, partial regeneration, repair, contraction, involution. What is wound healing? Who can define wound healing? Wound healing is defined as the replacement of dead tissue by healthy one. So, what is the correct option here? Correct. D. Oh, sorry, number 5. Which is odd regarding the process of wound contraction? It entails inward movement of viable tissue margins. It's dependent on the degree of fixity of the skin. It's determined by the amount of available skin. Occurs immediately after infliction of injury, which is odd here. Correct. D is the odd one. 6, the phenomena of repair in the healing of wounds in human simply the replacement of lost tissue by A, granulation tissue, B, fibrous tissue, C, type, tissue similar in type, D, mechanical reduction in size of defects, E, tissue identical in type. What is our answer? Okay, they can't hear the answers. The answer here is B. So you are the ones confusing them. Wound healing in humans may involve the following processes. A, contraction, reconstitution, and repair. B, contraction, regeneration, and repair. Reconstitution, regeneration, and repair. Contraction, regeneration, and reconstitution. E, reconstitution requires some degree of regeneration. There's no regeneration in human being. If you lost your limb now, we need to regenerate, except if you are Hydra. You know Hydra? You don't know Hydra in biology? The organism that can regenerate a limb. But if you lost your limb, it will not regenerate. The only tissue that has some degree of regeneration in the body is the liver. Okay, but there are some lower animals, okay, invertebrates that have degree of regeneration like Hydra. But in humans, it's repair. That's why you have replacement by fibrosis, for fibrous tissue. So your correct answer here is B. Contraction of the edges. Is it contraction? Regeneration in the liver. That is the only tissue that will have some degree of regeneration in humans. But all other tissue cannot regenerate. They repair. And most of our repair is by replacement with fibrosis, fibrous tissue. The next question is, process of contraction in healing wound occurs maximally in day 2 to day 12, day 3, 13, 4 to 14, 5 to 15, 6 to 16. Yes? Now, if you look at the phases of wound healing, you have the inflammatory phases also, which occur in the first 72 hours. Then you have the proliferative phase, okay? That occur within 5 days to 2 weeks. Then you have the maturation phase and remodeling phase that takes a longer time. So usually after the inflammatory phase, during the proliferative phase, the proliferative phase is characterized by 3 major processes: epithelialization, granulation tissue formation, and new vascularization, formation of new vessels. It is during these processes where the granulation tissue is formed, and you have special type of fibroblasts that are called myofibroblasts. They are the ones that cause wound contraction, and it occurs between 4 to 14 days. Okay, let's go on. Under normal circumstances, the smallest proportion of pre-injury mass of liver that regenerates, okay, normal liver mass is, under normal circumstances, the smallest portion of the liver that regenerate is what proportion? 4/5, 3/5, 2/5, 1/5, 3/4. Who knows? Yes? Yes? It's 2/5. He's right. But don't confuse us. You scare us. Where are you talking from? Okay. Collagen is made up of principally of which of the following amino acids? Collagen. You know, there are various types of collagens. Okay? You have like 18 types or even more. But the ones you need to know are called SCAB. SCABS or SCAB, SCAB. And there are various locations. Type 1, type 2. You are just moving purulent stuff. So type 3. Type 3 and type 4. Okay. Now, type 1 is predominant in the skin. Type 2 is predominant in connective tissues. Type 3 is predominant in arteries. And type 4 is predominant in basement membrane. And of course, you know, in the maturation of collagen, vitamin C is required for the hydroxylation of proline and hydroxylysine. So without vitamin C, you will not have adequate wound healing, because vitamin C is part of the nutrient that is required for the hydroxylation of proline and lysine. So, our options here. Collagen is made principally of which of the following amino acids? I've already told you the answer. So, which is the answer? So your option here is E. Which is odd regarding ideal suture material. I believe you all know what suture is. A suture, what is suture? Yes, Hafsat. Hafsat is a surgeon. Do you want to become a surgeon or a gynecologist? Gynecologist. Surgeon, that is very good. That is the correct definition for sutures. It's a strand of material that is used to approximate wound edges or ligation of blood vessels. That is excellent. Now, ideal suture. Evoke minimal tissue reaction. Be chemically inert. Retain its tensile strength indefinitely. Produce no mechanical irritation. Exert antimicrobial influence. What is odd here? You want it to produce mechanical irritation. An ideal suture should be inert now. And if it is inert, it will not produce any irritation. Retain its tensile strength indefinitely. Ideal. Now, you see, that suture material is not an antibiotic. It's just to approximate wound edges and ligation of blood vessels. So E is not correct. Do you understand? Are you accepting those in the waiting room? Which of the following may speed up wound healing? Parenteral iron, oral vitamin C, topical insulin application, parenteral methionine and cysteine, topical vitamin A. Yes, what is our option? Speed up, to speed up. Okay, what is the message on the group? Somebody said B. Which of the following may speed up wound healing? Parenteral iron, no. Now, there are wound healing vitamins, you should know. Vitamins are A, E, A, E, and C are wound healing drugs. Okay? A, E, and C. But of course, you know their role. The various roles of this vitamin, you know, vitamin C is hydroxylation of proline and lysine. Vitamin A is epithelialization. And vitamin A enhances or it speeds up. It speeds up wound healing. So your answer is E. Well, it's a factor that is required, but not speeding up. Because that is for collagen formation, while this is for epithelialization. E is a coenzyme. Which is odd regarding wound dehiscence? Which is odd regarding wound dehiscence? Is most common in upper abdominal incision. True or false? Upper abdominal incision, is wound dehiscence common there? False. It's not common now. Why? Okay, let's see the other option. It's casually related to use of inappropriate rapidly absorbed suture material. Is adversely affected by poor nutritional status of the patient, like hypoproteinemia. Follows increased abdominal strain in 90% of cases. It's not prevented by use of abdominal binders. Now, upper abdomen, the layer of rectus, both the anterior and the posterior rectus is intact. But the lower abdomen is only the anterior layer that is present. The posterior layer is deficient below the arcuate line. That's why you see most incisional hernias occur below the umbilicus, because the posterior layer of the fascia is deficient, if you remember your anatomy. So A is true, it's not odd. B is also true. It's causally related to use of inappropriate rapidly absorbed. If you use Vicryl, that the absorption is 90 days to 120 days, and the tensile strength of a fascia attain 80% of the tensile strength in 2 years. And you are using a suture that is absorbed in 90 days to suture a fascia. You are using inappropriate suture and absorbable suture to suture that fascia, so it will break down. You actually use non-absorbable sutures like nylon to suture fascias. That's why in the past, when after cesarean section, the gynecologists often use Vicryl to close the rectus, and the incidence of incisional hernia is high. But when they use nylon, it reduces the incidence. So B is true. C is obviously true. Now D is odd. Sorry, we are reversing all the options. We said it's most common. A is false. Is that not so? So causally related to use of inappropriate rapidly absorbed suture material. Okay? Is adversely affected by poor status. Okay, that is true. D is also true. Is that not so? If the patient is coughing, straining, you went and did a surgery for a patient is having cough, there's going to be a problem. The wound will break down. So your answer here is what? Okay. The answer is the one that is odd here is A. Okay. Which is false regarding epithelialization? Which is false regarding epithelialization? A starts when well before any evidence of fibrosis. Start too early to exert any protective function in healing wounds. Contribute significantly to the tensile strength of a healing wound. In this process, in wound healing, is that process in wound healing which in the appropriate circumstances may lead to neoplasia, may be complicated by implantation dermoid. So which is false? Regarding epithelialization, which is false? Yes? Who want to attempt? Which is false? A is correct. I told you there are three processes during proliferative phase: epithelialization, granulation tissue formation, and what? Neovascularization. Epithelialization even starts before you have any formation of fibroplasia and all that new blood vessels and co. Start too early to exert any protective function in a healing wound. You see, after 24 hours, after 48 hours, epithelium has sealed up a wound. A patient can take his bath after 48 hours, especially if it's a clean wound, because epithelialization has sealed the wound. So B is correct. Contributes significantly to the tensile strength of wound healing is false. It doesn't. Is that process in wound healing which in the appropriate circumstance may lead to neoplasia. And of course, you know, neoplasia tends to occur at the epithelial edges if you have appropriate stimulus for that. May be complicated by implantation dermoid. That is true. So the false answer here we said is C. It doesn't contribute to tensile. Epithelialization does not contribute to tensile strength. Which is not true regarding wound scab. I believe you know what a scab is. Is constituted by desiccated fibrin or blood clots and wound debris in the epithelializing wound. That is correct. That is what a scab is. Protect the wound from physical trauma, desiccation, hemorrhage, and caustic and bacterial agents. That is what it does. Development is distributed by frequent wound dressing. Is evidence of uncomplicated wound healing. Should be peeled off at time of suture material. That is false. Just remove your suture and leave it alone. Keep on pulling it, you just be bleeding. And you are even exposing the wound to other vices that I mentioned above. Regarding the scab of a healing wound, which is true, consists of blood clots only exposed to the atmosphere. Consists of blood clots overlaid by migrating keratinocytes. Separates spontaneously by the second day of healing process. Serves no particular function in either indicative of attendant wound infection. Okay, regarding scalp, what is our correct option here? Who wants to try? So the answer is B. B for boy. Which is odd regarding granulation tissue? Odd results from excessive epithelial cell proliferation and migration. That is odd because granulation tissue is composes of what? What forms the granulation tissue? What forms a granulation tissue now? Is it not the new the new blood cells that are formed, the ground substance and collagen? They form the granulation tissue. So it's not epithelial proliferation. That is false. It contains macrophages, which has phagocytic function. Yes. It's fragile and produces a difficult terrain for advancing epithelial cells. It's unhealthy when fibrous tissue interfere with its return circulation. It's a principal agency for healing by secondary intention. Which is true about collagen found in healing wounds. It's composed predominantly of hydroxylysine. It is constructed by an intracellular process by fibroblasts, directly incorporates dietary hydroxylysine, progressively increases in quantity as the wound gains tensile strength. Ab initio is horizontally arranged in the wound. Now, don't forget, it is the fibroblasts that form collagen. Fibroblasts, they are the one that form collagen. So that is the correct option. Which is false regarding resutured wound? Heals B now. We said B is constructed by an intracellular process of fibroblasts. B is the option. Which is false regarding resuturing? Heals faster than fresh wound suture at the same time. True or false? Which is false. Now, if you have an old wound, okay, or maybe you have a wound in the abdomen, you want to re-enter the abdomen. If you make a fresh incision and going through that previous incision, which one do you think will heal faster? Fresh or the old one? I know you like fresh things, but you are wrong. Why? Oh, you just guessed. Is it in your hair or in your head? Because I know you barb the hair. See, there is what is called lag phase of wound healing. Lag phase, L-A-G. Lag phase of wound healing comprises of the inflammatory phase and the demolition phase. At that phase, the wound has zero tensile strength. Now, when you make an incision, a fresh incision, it will still pass through the lag phase, while the old one has already elapsed the lag phase, so it will heal faster. You understand the reason? I believe it is very clear. So A heals faster than fresh wound. So that is true. In the early weeks of repair, has a greater tensile strength than the fresh wound, sutured at the same time. That is true. Heals under the influence of wound hormones. That is false. Has shorter lag phase of wound healing. That is true. I've explained that. Which of these trace elements has been demonstrated to exert beneficial effect on wound healing? Copper in malnourished adults. Zinc in children, especially in the Middle East. Chromium in anemic patients. Iodine, magnesium. Which one has been shown to demonstrate benefits wound healing? The zinc. So your answer is Biko. Okay. Zinc is a micronutrient that is essential in wound healing. Ulcers on the lower third of the leg in the aged tend to heal poorly primarily on account of what? Why do their ulcer heal poorly? Repeated trauma. B, impaired venous drainage in the area, attendant lymphatic obstruction, compromised arterial inputs, excess movement of underlying muscles. What is our option? Yes? The answer is D. Compromised arterial inputs, poor blood supply. 22, keloid formation in healing wounds. You know, keloid is a common question, even in picture tests. A is most frequently encountered in surgical scars. It's more likely to occur in older patients more than 60 years. Has predilection for abdominal wounds. Occur within 3 months of injury. Has been genetically linked to HLA-B14 and blood group A. What is our answer? E is correct. Is not frequently encountered except in patients that are prone to keloid. Do you understand? It's not frequently encountered. Okay? It doesn't occur mainly in more than 60 years, usually around the middle age. It has predilection to the peristernal area, head and neck region, earlobes, but not abdominal wound. Malignant degeneration of a wound is most likely to occur A, when there is recurrent infection, when wound is repeatedly traumatized, when wounds are exposed to heat, when wounds are exposed to X-ray, when patient is on cytotoxic agents. Yes? Option, yes? All of the above. malignant degeneration of wound is most likely to occur when? Yes. No, a single best option is not the best among all these. Single best option. Yes. The answer is D. D. All these other options can cause chronicity, but exposure to radiation is a risk factor for malignant degeneration. Is it clear? All this will cause persistent stimuli. It's chronicity that may become malignant. But the most appropriate here is exposure to radiation. Is it clear? Which of these suture materials is or are absorbable? I believe you know absorbable sutures. Polyglactin, that is Vicryl, is absorbable suture. Olon, Dacron, Teflon, polypropylene. So which one is absorbable? A is correct. Which of these suture material is are non-absorbable? Non-absorbable. Yes. Is polypropylene. Which of the following is true about shock? Where is that? Okay, thank you. Thank you. Which of the following is true about shock? There is adequate tissue perfusion. The blood volume is reduced. There is cellular hypoxia. Cardiac function is impaired. There is vasoconstriction in the microcirculation. The hallmark of shock is what? Is cellular hypoxia, correct. Microcirculation consists of what? What makes up the microcirculation? Correct. So what is your answer? The answer is D. D. D for dog. Which of the following is false about circulation? Which is false about circulation? Each heartbeat propels 70 to 90 mils of blood at a pressure of 120 millimeters of mercury. That is a correct information. Each heartbeat. About 30% of blood is contained in the microcirculation. 20%. It's not up to 30%. Only about 1/5 of the capillaries is normally open at any time. That is correct. The average adults, 75 to 80 mils of blood per has 75 to 80 mils of blood per kilogram body weight. That is correct. Which is true regarding hemorrhagic shock. Which is true regarding hemorrhagic shock. The serum catecholamines are elevated. Renal excretion of sodium is usually increased. Metabolic activity is increased. Immunity is depressed. Hemorrhagic shock. Catecholamines are elevated in order to what? Cause vasoconstriction, to reduce blood loss. So A is correct. Poor tissue perfusion is suggestive of all except cold extremities, restlessness, oliguria, anxiety, hypertension. E. Which of the following signs of hypovolemic shock is not due to vasoconstriction? Not. Cold skin, pale conjunctiva, restlessness, collapsed peripheral veins. So what is our option? D, restlessness. And C is the answer, restlessness, yes. In the management of hemorrhagic shock, which crystalloids, with crystalloid, which is odd? Management, which is odd? Rapidly restore the volume of blood. B, you see, crystalloid is what you use initially. If a patient is losing blood, don't go and give blood. It is, you commence resuscitation with crystalloid first. And obviously, you know the reason. Lower the viscosity of the blood and thereby improves microcirculation. That is correct. C, may make blood transfusion unnecessary. That is correct. So A, B, C. And B gives you the reason why you don't use blood first. Do you understand? Because you want the oxygen to get to cellular level. And if you give colloid, it will remain in the intravascular space. Once you give crystalloid, only 1/3 remains in the intravascular space, 2/3 moves into the interstitial space, enhancing microcirculation and delivery of oxygen to tissue. May make blood transfusion unnecessary. Of course, that is true. Improve oxygen uptake by the tissue. That is what we just said. Do not affect blood product requirements. That is false. Perhaps the most effective drug to use in hemorrhagic shock. If tissue perfusion remains inadequate, in spite of adequate fluid therapy, what will you give? You give vasodilator, correct? So which one will you give? A, isoproterenol, dopamine, phenoxybenzamine, chlorpromazine, dobutamine. Yes? Yes. You give dopamine. That is B. Now, how will you know? It is when patient is having normal or elevated central venous pressure. It means there is enough fluid in circulation and yet, okay, there's ineffective perfusion of tissue. So you now give vasodilators so that you dilate the vessels, there will be adequate perfusion. Is it clear? Dopamine is what is commonly used. In hemorrhagic shock, mannitol should be given to promote diuresis. Is that true? It's false. Because if mannitol is a diuretic, patient is losing blood and you are giving him diuretic, you want to kill that person. A is false. It's advisable to use alkali to correct acidosis. Is that true? No. You give fluids. Hydrocortisone is of proven value. Proven value. True or false? Proven value. False. It has not been proven. Even though we give it in septic shock. Raise the leg. Okay. Raising the leg will increase venous return by about 2 liters. That is correct. Acidosis with hypokalemia may be expected to supervene. Now, when you have acidosis, there is hyperkalemia. Alkalosis, there is hypokalemia. I believe you know the reason. The most useful single observation during treatment of hypovolemic shock, the most useful single observation during treatment of hypovolemic shock is the most useful single. The most reliable marker for tissue perfusion is urine output. So your answer is D. All can lead to irreversible shock except irreversible. Inadequate fluid resuscitation. Replacement, that is correct. You are not giving enough fluid. Continued blood loss, that is correct. Metabolic alkalosis. True or false? Are you sure? Undetected organ injury, true. Multiple use of antibiotics. Multiple use of antibiotics. So between C and E, which one is correct? If a patient has alkalosis, what will happen? Yes. Metabolic alkalosis, what happens? Yes. They also have a refractory correction. Yes. So your answer here is C. Multiple use of antibiotics does not cause irreversible shock. Cause of shock, lung, that is acute respiratory distress, include all except direct effect of shock on the lung, direct injury of the lung, excessive fluid administration, oxygen toxicity, fat embolism, and thromboembolism. Now, the ARDS is not as a result of direct effect of shock on the lung. Okay? But all these others can cause it. So A is false. The following are released in septic shock. Septic shock is a form of shock caused by infection, microorganism, pathogenic microorganism that does not respond to fluid resuscitation. They do not respond to fluid resuscitation. They only respond to inotropic and chronotropic agents. You keep on giving fluid, they will not respond. The following are released in septic shock except A, noradrenaline and adrenaline. Histamine, thromboxane, A2, none of the above, all of the above. Noradrenaline and adrenaline. You know, in septic shock, we have a peripheral vasodilatation. Okay? Noradrenaline, the guys online are sending messages. He said A. So that is thromboxane, histamine and thromboxane A2 will cause vasodilatation. This adrenaline will cause what? Vasoconstriction. And septic shock is a form of what? Distributive shock. I think it's right. Which is true regarding septic shock? Never follows hypovolemia. That is false. There is a link between hypovolemic shock and septic shock. What is the link? Who can tell me? I have a prize for you. Who can tell me the link between hypovolemic shock and septic shock? I have a prize for you. Anybody that can tell me the link between septic shock and hemorrhagic shock and hypovolemic shock? What is the link? Hafsat is a surgeon. She has an idea, but of course, she has an idea. When there is blood loss, okay, you know there is diversion of blood from what? The splanchnic circulation to vital organs, stand also the brain and the heart. When there is that diversion, there is mucosal ischemia of the intestine. So because of mucosal ischemia, there is loss of integrity of the epithelium of the intestine and leading to transmigration of bacteria from the lumen into the systemic circulation, and that will lead to septic shock. Like here, I have not mentioned the price. Even though you did not get it completely. No, it's complete stops I want. You cause partial avulsion, and I told you there's still more bleeding in than complete. Never follow hypovolemic shock. That is false. May occur during treatment of septicemia. Is that true? It's always characterized by high output failure, always. Low peripheral resistance and normal or high central venous pressure. It's not caused by skin infection. It's likely caused by hypotension 2 hours after onset of severe acute pancreatitis. So what is our answer here? A is false, obviously. During treatment of septicemia, it can occur, especially when you don't treat it properly. You are not using appropriate antibiotics and the disease progresses. That is correct. It's always characterized by high output failure. High output failure. Low peripheral resistance. Normal or high central venous pressure. That is why it's wrong. The central venous pressure is low. It's not normal, it's not high. It is less than 8 millimeters of mercury or less than 10 centimeters of water. So it's low. That's why it's false. Now, D is also false because it can occur from skin infection. Okay, let's go on. We still have a lot of questions. How many minutes do we have left? Okay, we have 30 minutes to go. In most cases of septic shock, the skin is warm and dry initially. Skin is warm and dry initially. You know, septic shock is a form of distributive shock. And in distributive shock, you have peripheral pooling of blood. And the skin will be warm and dry. So that is correct. That also. What are other forms of distributive shock? Anaphylactic and what? And neurogenic shock. That is good. The pulse is initially rapid and feeble. The pulse is initially rapid and feeble. Is that true? Initially, they have a bounding pulse. Initially, it's a hyperdynamic state. Shivering may precede the attack. You're already yawning. Apprehension and confusion may be the initial manifestation. So the only odd one here is B. All these others are correct. In the treatment of septic shock, blood is needed urgently. Is it true? Blood is not needed urgently. Corticosteroid given in massive doses have been shown to inhibit the production of arachidonic acid derivative by complement activated polymononuclear It's not true. We said it has not been proven. Antibiotics are not particularly beneficial as the organism is are already dead. Is that correct? It's false. Fluid therapy is of secondary importance. Now, you should know that fluid therapy is the first treatment of choice for all forms of shock. Fluid therapy. So he is false. So what is our correct answer here when we say everything is false? Let's look at them carefully. When you start seeing this, you have to look at them carefully. Corticosteroids given in massive doses have been shown to inhibit production of arachidonic acid. So that is the more likely among all these options. Even though you see the use of steroids are controversial, okay, some texts will say they have not been proven. But comparing to all other options, this is the more appropriate B. Which of the following is typical of neurogenic shock, vasovagal syndrome, sweating, hypotension, pallor, bradycardia, loss of consciousness? Yes, the answer is D. Neurogenic shock. It's a form of distributive shock. And in vasovagal syndrome, this neurogenic shock usually occur maybe in spinal injury. Okay, they can have bradycardia. In anaphylactic shock, which is also a form of distributive shock, which is false, reticular endothelial cells are involved in the antigen-antibody reaction. Adrenaline, histamine, plasma kinase are among the substance released. There is generalized vasoconstriction of peripheral vessels. The bronchioles are constricted. Penicillin injection may be the cause. So what is our answer? Correct, because we said there is peripheral vasodilatation. So C is false. Two days after resection of a segment of gangrenous ileum, a patient becomes apprehensive and confused. The skin is warm and dry. Temperature is 39. Blood pressure 90/60. Pulse 20, 120, and bounding. The abdomen is slightly tender and breathing is rapid. The most likely clinical diagnosis is what? A, hypovolemic shock, septic shock, malaria, anaphylactic shock, peritonitis. What is our answer? Correct, septic shock, for obvious reasons in the question. The less important measure to adopt regarding previous question is less important. A, intravenous antibiotics, rapid infusion of Ringer's lactate or normal saline, intravenous hydrocortisone, rapid infusion of blood. Why blood? Yes, that is your correct. You said? Yes, it's the less important. So you are right. The answer is D. Which of the following does not cause vasodilation? Does not. Kinins. Prostacyclin, thromboxane A2, C5A, C5, C3 components. Serotonin. Now, kinase causes vasodilation. Prostacyclins also. Now, thromboxane A2, what do they do? They cause vasoconstriction and platelet aggregation to limit blood loss. Is that also? So the answer there is C. All these others cause vasodilation, histamine, serotonin, all those. Now, in systemic inflammatory response syndrome, SARS, there must be two of the following, two or more of the following: temperature greater than 38, less than 36, heart rate more than 100, respiratory rate more than 25, partial pressure of carbon dioxide less than 32, white blood cell more than 12,000. What is the correct answer? Odd one. B is 90 now, Abby. 60. Are you serious? Is it a machine or a robot? So the answer is B. That parameter there is 90, not 100. And respiratory rate should be less than 20, or partial pressure of carbon dioxide, greater than 20, or partial pressure of carbon dioxide less than 32. That is the correct option. So B is not 100, but 90. Okay? So, so many questions in the chat box. Okay. Where are we? So what do we say is our answer? Are we looking for the odd one? But A is correct. Is that not so? B is 90, C is 20, not 25. So it's not correct too. Because that respiratory rate should be more than 20. Is that not so? Not 25. White blood cells should be either greater than 12,000 or less than what? 4,000. It's not 3,000. Or immature band form, 10% immature band. So the answer here is A. All these other options, you see why one have to be very careful with MCQ. Look at how 25 is manipulated. Look at how 4,000 is manipulated to 3,000. And we've already passed the question and choosing odd one. After recovery from moderate blood loss, the hematocrit is raised, the extravascular fluid volume is increased, production of red blood cell is maximal in 7 to 10 days. Erythropoietin production is stimulated by interleukin 6. Serum protein level is increased. What is our answer? 48. What is correct? C is the correct option. Production of red blood cells is maximal in 7 to 10 days after moderate blood. In septic shock, the plasma level. In septic shock, plasma level of platelet activator factor is raised. Thrombomodulin is elevated. Protein C is raised. Protein S is raised. Antithrombin 3 is raised. The answer is A. PAF is raised. 50. How many more minutes do we have? Activation of neutrophils in septic shock leads to all except A. The adherence to and damage of vascular endothelium, tissue infiltration, increased phagocytic activity against all bacteria, production of nitric oxide. Except activation of neutrophils in septic shock leads to all except A is correct, B is correct, C, increased phagocytic activity against all bacteria, all bacteria. So you know, there are some bacteria cannot phagocytose. Like which one? Like which bacteria? So the answer here is C. Production of nitric oxide, that is correct. So I think since we are at 50 questions, we are going to stop here. If you come early in the morning, we'll complete the 50 questions before we can start the business for tomorrow. So thank you very much, everyone. You are all welcome.